Hi everyone, welcome to today's LACNETS webinar. I'm Lindsay Judavine, the Director of Communications for LACNETS.
And I'm Lisa Yen. I'm the Director of Programs and Outreach.
Before we get started, I'd like to take a second to thank Rich at TVP Live for making today's webinar and high-quality production possible. We'd also like to thank our supporters, Ipsen, Advanced Accelerator Applications, and Novartis. We will be having a live Q&A following today's presentation. To submit your non-case specific questions, go to www.slido.com/LACNETS3. While we do our best, we will get to as many questions as possible, but unfortunately, it's not possible to get all the questions. Feel free to reach out to us or submit your questions again at a future program. Here are a few tech tips for today's webinar. For your audio, be sure the volume on your computer screen is turned all the way up. Double check that the volume is unmuted on the webinar broadcast screen. And also, the closed captioning feature is offered on our YouTube live broadcast. For your video, you can enlarge the webinar broadcast screen by clicking the Expand Screen button in the bottom right corner. Also, as a reminder, our monthly educational webinars are recorded and can be viewed on our YouTube channel shortly after the live broadcast. If you haven't checked out our LACNETS YouTube channel yet, our channel consists of a video library of more than 150 NET videos. Our channel features presentations on a wide range of NET topics not covered in today's webinar. Be sure you're following LACNETS on social media. Stay up to date on upcoming webinars and NET news. We're on Facebook, Twitter, and Instagram with the handle @LACNETS. And before I pass it off to Lisa, I'd like to remind our viewers that these webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. And now I'll pass it off to you, Lisa.
Thank you, Lindsay. LACNETS is a program by GeneratePossibility.org, a registered nonprofit, and it stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer as a patient-friendly way to say the official medical term, neuroendocrine neoplasm. We also say neuroendocrine cancer because we understand NET is a type of cancer and not cancer-like, as previously thought. While you often see Lindsay and I leading the meetings and programs, we are in fact led by a team that includes our Executive Director and Board Member, Kavya Velakapudi, and Board Member Donna Gavin, who is also the sister of LACNETS founder and Executive Director Emeritus Giovanna Joyce Mbasi. Our board also includes Mary Dunleavy, who has been living and thriving with NET for over 17 years. I'm pleased to introduce our featured speaker for today, Dr. Aman Chauhan. Dr. Chauhan is a board-certified medical oncologist at the University of Kentucky's Markey Cancer Center. He earned his medical degree in India and then completed a dual residency in both internal medicine and pediatrics at LSU in New Orleans. Dr. Chauhan completed a fellowship in hematology oncology at University of Kentucky with focused neuroendocrine tumor training. Additionally, Dr. Chauhan completed a cancer therapy evaluation program physician externship at the National Cancer Institute, which focused on training early career physician scientists in designing clinical trials and clinical research projects. His clinical interests include the treatment of NETs, including carcinoid tumors, high-grade neuroendocrine carcinomas, and small cell carcinoma. Dr. Chauhan is the director of NET Diagnostics at Markey, and he identifies NET patients who qualified for PRT treatments for NETs. Dr. Chauhan is leading multiple NET phase 1 and 2 clinical trials and is currently funded by the NCI to study DNA PK inhibitors in preclinical NET models. Dr. Chauhan is a co-author of over 50 PubMed index manuscripts. It's clear Dr. Chauhan is very committed to helping the NET community. He's a very busy man who is deeply committed, and not only is he involved in research and seeing patients, Those of us who know Dr. Chauhan know that he's also very active in the patient advocacy community and have seen him as a featured guest on the Carcinoid Cancer Foundation's Luncheon with the Expert or NCAN conferences or a local support group. I first met Dr. Chauhan in person back in October 2019 at the annual LACNETS conference where the medical professionals gather to network and share their work. His passion is palpable and his excitement contagious. And as I mentioned earlier, Dr. Chauhan has a special interest in the high-grade population, which is why we invited him to speak today. Welcome, Dr. Chauhan.
Hello, everybody. My name is Dr. Aman Chauhan. I'm one of the medical oncologists at University of Kentucky Markey Cancer Center, and I direct our Neuroendocrine programs, and I also specialize in management of high-grade neuroendocrine cancers. Today, we would be talking about what high-grade neuroendocrine cancers are and certain updates in their management, both diagnostics as well as therapeutics. As you all probably know, neuroendocrine cancers can originate at various organs: lungs, GI tract, pancreas, rectum, ovaries, breast. These are relatively rare cancers as compared to some of our other cancers, but have high prevalence because many neuroendocrine cancers, especially the low grade and intermediate grade, they live for much longer. So the cumulative prevalence of neuroendocrine cancer far outweighs the incidence of these tumors. The biology of these cancers are very heterogeneous. Some of the neuroendocrine cancers can be very slow growing or indolent, and others can be very aggressive. And one common denominator for most neuroendocrine cancers is the limited treatment options as compared to some of our other common cancers. However, we are making some progress in that domain. I would like to begin with showing the Seer database analysis from Dr. Desari's group in MD Anderson. What we see here on the top, the blue line, the incidence of most common cancers in the United States have leveled off in last 4 decades, which is a good news. We are not seeing the rate of incidence increasing over past 40 years. However, what is concerning is the incidence of neuroendocrine cancer has shot up 6 to 7 times in the same time frame. And these are low as well as high-grade neuroendocrine cancers. What is even more worrying is the cumulative prevalence. Most of these patients often survive long time. So the new additions or the new diagnoses add on, and as of now, there are over 170,000 patients with that diagnosis of neuroendocrine cancer in the United States alone. In fact, the prevalence of GI origin neuroendocrine cancers is now second to colorectal cancer in GI tract in terms of prevalence. However, for today, we will be primarily focused on high-grade neuroendocrine cancers. And before we go into that, we will first understand some of the terminologies associated with neuroendocrine cancers. These can be very complex, and even in medical community, there's a lot of confusion about the neuroendocrine cancer terminology. So let's break it down a little bit. Because there are 2 different WHO committees who determine how we classify neuroendocrine cancers. One is primarily the lung WHO committee and the other one's GI. There is a little bit of discordance in how we name these cancers, but you will start recognizing that we are essentially talking about similar biology of cancers. I have laid out the spectrum of GI neuroendocrine cancers and the lung neuroendocrine cancers side by side. And very soon you'll start joining the dots that we are essentially talking about the same type of cancers. In GI world, the neuroendocrine cancers can vary from low grade, well differentiated NET to all the way high grade, poorly differentiated NECs. And within NECs, there are 2 subtypes, small cell and large cell. Now, well-differentiated NETs can be further 3 subtypes, grade 1, grade 2, and grade 3 based on Ki-67 index. Now let's focus on lung neuroendocrine cancers. The WHO classification for lung neuroendocrine cancers they like to use word typical carcinoid for well-differentiated NET, atypical carcinoid for intermediate differentiation NET. Both are essentially well-differentiated NET, just different grades of them. And NEC, which is poorly differentiated neuroendocrine carcinoma, further two subtypes, small cell and large cell. So now you can start seeing the commonalities. The well-differentiated NET is like typical and atypical carcinoid of lung, and NEC, the poorly differentiated neuroendocrine carcinoma, which can be of further two subtypes, small cell and large cell. They are same for both GI and lung, and we call them NEC. So the first main distinction that we have to make is NET versus NEC. Let's go over some of the subsets of these neuroendocrine neoplasm, and let's see how prevalent or common they are in the different organs. If I divide all lung cancer in a pie chart, most of the lung cancers are actually non-small cell lung cancer, like adenocarcinoma, squamous cells, etc. But there is a sizable portion of lung cancers which together form neuroendocrine cancers. These include carcinoid, which is well-differentiated NET, or atypical carcinoid, large cell neuroendocrine cancer, and small cell lung cancer. Now together, they might form up to 20%, depends on which part of the country you're from. The incidence of small cell and large cell neuroendocrine cancer in my part of the country, in Appalachia, is a little bit higher than the rest of the country. And the incidence of small cell lung cancer especially is much lower in East Coast and West Coast. But overall, 14 to 20% of all lung cancer are of a subtype of neuroendocrine cancer, either low grade like typical carcinoid or high grade like small cell or large cell. Now let's talk about GI tract. In GI tract, this percentage is flipped. When we talk about neuroendocrine cancers of GI origin, including pancreas, majority of these neuroendocrine cancer belong to low grade, well-differentiated grade 1, grade 2, up to 85%. And only 15% of the GI neuroendocrine cancer high grade, either well-differentiated NET or NEC, comprises just 15% of this group. So majority of GEP-NETs or GI origin neuroendocrine cancer are actually grade 1 or grade 2 NETs. This is the most critical element of the management, and that is getting the pathology right. In past, there has been a lot of discrepancies between different pathologists, and fortunately with better guidelines and better classification, we now are getting more and more accurate in diagnosing these cancers. This is how the neuroendocrine tumor cells, the well-differentiated NET cells, looks under the microscope. So they have particular patterns, a glandular pattern or diffuse pattern. And in the center, you can see a slide which looks a little bit bluish, but has some brown stain on it, which is Ki67. And these tumor, because it is a well-differentiated NET grade 1, the Ki67 is very minimal, less than 2%. So it is taking very limited amount of the brown stain as compared to grade 3 NEC, where morphologically or their appearance is very different. They don't have that glandular pattern. They can be either small cells, so small round blue cells on the left hand of your screen, versus a more diffuse large cell sheets of cells, large cell neuroendocrine carcinoma. But in the center, the Ki67, as you can see, these cells take a lot of Ki67. So these are much more brown as compared to the previous slide. So very aggressive cancer, very rapidly dividing cancer, so high Ki67. In fact, by definition, all NECs are grade 3. That means their Ki67 more than 20%. But many a times, the NEC subgroup have Ki67 over 50%, and small cell are usually over 90%. So based on these findings, we have now recognized two different subsets of high-grade neuroendocrine cancers. Before 2017, when we said high-grade neuroendocrine cancer, it always meant grade 3 poorly differentiated neuroendocrine carcinoma, that is either small cell or large cell. But over the recent years, we have recognized that there are some well-differentiated NET that can also be high grade. That means they can have Ki67 more than 20% and yet also have this well-differentiated NET pattern or morphology like we see with grade 1, grade 2. So when we see a patient with high-grade neuroendocrine cancer, it's really important for us to determine, are we talking about grade 3 NET or NEC? All NEC by definition, as you can see, would be grade 3, but not all NET are grade 3. Majority of NET, as I mentioned before, 85% of NET are grade 1 or grade 2 in GI tract, but a minority subset can be grade 3, and we really need to recognize those. In subsequent presentation, we will then talk specifically about how to manage grade 3 well-differentiated NET and NEC. The other advance we have made in this area is that we are not only getting better at recognizing these cells under the microscope, and there are much clearer guidelines from WHO how to detect grade 3 NET versus NEC. We have also now learned quite a bit about their genomics and the molecular underpinning. A lot of this work has been led at Memorial Sloan Kettering by two really good pathologists, especially Dr. Laura Tang. She is a very famous pathologist and does a lot of GI, pancreatic, and midgut NET sequencing. And what they have found that the spectrum of these neuroendocrine cancers also happen to have different spectrum of mutations. If you look in this slide, the well-differentiated NET group tend to have loss of DAX, ATRX mutation. Some of them might have MEN1 mutation or mutations associated with PIK3 mTOR pathway. In contrast, if you look under the poorly differentiated red category, these are the NEC, the mutation profile is a little bit different. They either have mutation in TP53 or loss of RB1, SMAD4, KRAS, etc. So what we foresee as the time progresses, it might not be surprising to see the future iteration of WHO classification incorporating these molecular biomarker in the actual classification. Right now, the classification is based on how the Ki67 is, how the cells look under the microscope, small round blue cells, the large cells, the diffuse patterns, all morphological. But very soon we might see that we are incorporating the next-gen sequencing, the mutational profiling of these cancer, which might help us diagnose these tumors even better. This is also true for high-grade neuroendocrine cancers of lung. One of the subset of high-grade neuroendocrine cancer of lung, the large cell neuroendocrine cancer, has been an enigma for a long time. And we don't really know how to treat them. We don't even understand, are they similar to small cell or are they similar to non-small cell? So Dr. Reckman, again, a very good and leading pathologist, thoracic pathologist at Memorial, she sequenced many large cell neuroendocrine cancer samples from lung patients at Memorial. And what they found that when you looked into the genomic fingerprinting of these large cell neuroendocrine cancer from lung, only 40% of these actually have mutations consistent with small cell lung cancer, and the majority were actually like non-small cell, and then a very small minority like carcinoid. So there is growth in our understanding how these large cell neuroendocrine cancers not essentially or necessarily are small cell like. They could actually harbor a completely different mutational pattern. And we are now using this information in determining how should we treat these patients. Thoracic large cell neuroendocrine cancer, there is no current consensus how to treat them. Many patients are treated like small cell lung cancer, but there are oncologists who would treat large cell neuroendocrine cancer of lung like non-small cell. So this data from Dr. Reckman does help us understand how to best treat it. And we are currently doing a clinical trial at Markey Cancer Center where we let this genomic signature determine how should we treat the patient. If there is TP53RB1 co-mutation, then we treat them like small cell lung cancer with platinum doublet. Or if they are a non-small cell, then we treat them with site-appropriate adenocarcinoma regimen. And this study is currently enrolling. Now, let's come back to the main topic for today. How do we go about managing high-grade neuroendocrine cancer? I hope that we have some idea about different subtypes of neuroendocrine cancer, low-grade versus high-grade, and the two major differences between high-grade, the well-differentiated NET versus poorly differentiated NEC. With that background, let's move forward. How do we diagnose high-grade neuroendocrine cancer? For sake of completion, let's go over some of the blood tests that we like to do in neuroendocrine cancer patients in general. Based on if it's NET versus NEC, our diagnostic workup can vary. Especially for blood tests, NET patients can have elevated chromogranin A, pancreastatin for pancreatic neuroendocrine tumor, elevated serotonin in lung nets or midgut nets, and urinary 5-HIA, which is the gold standard way to measure breakdown product of serotonin in the urine. And one of the biomarkers for high-grade poorly differentiated NEC is called NSE, neuron-specific enolase. Now, this is all great. We have so many blood tests, but unfortunately, all these blood tests are very non-specific, except for maybe serotonin. Most of these could be falsely elevated. So please take it with a grain of salt. In fact, many providers don't even routinely monitor these. And that is because sometimes they can cause a lot of anxiety in both patients and doctors because of the false elevation. However, if we do decide to do them, please take these results in context of the totality with imaging studies, etc. However, we are also working on new generation blood-based biomarkers, which might help us get to a much accurate test. And the lure of finding these blood tests, the accurate blood test, is that wouldn't it be wonderful if we have a quick and easy blood test to monitor the disease rather than waiting every 4 to 6 months for scans for low-grade nets and every 2 to 3 months for high grades. So that struggle is ongoing, but we had some promising results from our recent study where we tested a new biomarker called HPG80 progastrin in both low-grade as well as high-grade neuroendocrine cancer and are seeing some promising results. This biomarker is now being tested in a multi-center clinical trial, and hopefully we can update you about newer data soon. After blood tests, the next step is imaging. What kind of scan do we like to do for high-grade neuroendocrine cancers? If we are managing well-differentiated NET, the grade 3, then we do like to get gallium-68 dotatate scan, which is basically a PET scan and helps us evaluate if the tumor expresses somatostatin receptors. It is really important to get this scan because we can, one, see if the patient would benefit from a treatment called PRRT, a radio-labeled lutetium-177 dotatate, which targets the somatostatin receptor positive disease. And moreover, it also gives us confidence in our diagnosis because a well-differentiated NET should have some degree of SSTR positivity. However, I would caution you that there are some grade 3 well-differentiated NET who are somatostatin receptor negative. In fact, as the grade of the neuroendocrine tumor increases, the receptor density declines. So the gallium-68 dotatate scan might be very avid or bright looking or higher SUVs in low-grade nets as compared to high-grade NETs. We often not do these gallium-68 dotatate scan in NEC because the prevalence of somatostatin receptor is very, very low. The other PET scan that we often use in high-grade neuroendocrine cancer management is Ftg Pet. This scan is really good in detecting high-grade cancers which are hypermetabolic. And as you can see here, this NEC patient, we can see hypermetabolic lesion in the lung. Now, this is really important to help us differentiate NEC versus NET. And if there is a heterogeneous disease, that means there is some clones of cells are behaving more slow growing, are more well differentiated, and there is a mix of poorly differentiated NEC clones. Having both gallium-68 and Ftg Pet can really give us a lot of important useful information which might help us determine the right next step for the patient. Of course, besides the PET scans, we do routine CT scans and MRI, and those are pretty standard, and they are the gold standard way to monitor the disease on treatment. These PET scans are usually done at one time during diagnosis, and FTG PET is not always done, but it is recommended in especially early stage disease to uncover distant metastases. So we have now diagnosed high-grade neuroendocrine cancers. We have done some blood work. We have done some scans. We know the staging. We know the extent of the disease in the body. Now let's talk a little bit about the clinical manifestation. How do high-grade neuroendocrine cancer present? As the data is very limited, most of the publications regarding the presentation come from small cell lung cancer world, which is one of the most common type of high-grade neuroendocrine cancer. So rarely high-grade neuroendocrine cancer present in early stage. This is a very aggressive disease. So many a times when the patient present to our clinics, they already have advanced disease. This is unfortunate, but it is very rare to catch early. And when it does metastasize, the common sites for metastasis are liver, bones, and in some cases, even brain. Now, this is especially true for small cell lung cancer, where up to 30% of patients can have brain metastases at the time of diagnosis. However, the other high-grade neuroendocrine cancers, the extrathoracic, large cell neuroendocrine cancers, or other cancers, other poorly differentiated neuroendocrine cancers, this incidence of brain mets is much lower. So for small cell lung cancer, it is very routine to get a baseline MRI of the brain. However, it is not mandatory to do so in other extrathoracic high-grade neuroendocrine cancers. What are some of the prognostic factors which determine which patient will do better than others? So clearly, we understood in the spectrum of disease, NEC is in the most aggressive end of the spectrum. So clearly, a pathology or biopsy report of NEC confers poor prognosis as compared to NET. In NET, we understand that there are different grades of NET, grade 1, grade 2, grade 3. Higher the grade, prognosis tend to be poor, the outcomes tend to be poor. But when we are talking grade 3 neuroendocrine cancers, both grade 3 NET versus NEC, the grade 3 NET does tend to do somewhat better as compared to NEC. Of course, the performance status of the patient, the strength, the physical fitness of the patient does have an implication in how the patient would overall do. And that's true for any cancer. The patients who are fitter to begin with, they tend to do better as compared to very frail patient at time of diagnosis. Stage of the cancer certainly have an implication. Early stage cancer, we treat with intention of cure. NEC, there would be a very high relapse rate. However, there would be a subset of patients who would have long-term disease-free survival in early stage. Extensive stage, unfortunately, is not curative treatment. We treat the treatment with intent of palliation to slow the cancer down and prolong the life. And extensive disease. So if the patient has a lot of disease at time of diagnosis, especially brain mets or CNS involvement or bone marrow involvement, which can be seen in small cell subtype of NEC, that really is a bad sign. It tells us about aggressive biology of the disease, and these patients tend to do a little bit worse as compared to the other NEC patients. Lastly, a small group of NEC patients, especially small cell lung cancer, can also present with paraneoplastic syndromes, with some neuropathies, etc. And that also confers poor prognosis. All right, so we are at the very last phase of our talk. How do we now treat high-grade neuroendocrine cancer? We've talked about how to diagnose them, understand them, and get appropriate diagnostic workup. So friends, right off the bat, we still have a whole lot that we need to do. There has been some advancement in the therapeutics of high-grade, but we are nowhere close to our goal. The 5-year survival of poorly differentiated NEC are still very low for advanced disease. I would say less than 10%. For small cell, it's actually less than 5%. So clearly we have a whole lot that we need to do to improve the outcomes of NEC patients. The 5-year survival for NET are better than NEC, but again, they are not as good as the grade 1, grade 2 NET. So clearly, we also need to improve in that area. If patient is caught early and we have diagnosed the disease in early stage, resection can be considered, curative resection, especially for NET. However, for NEC, usually resection is unlikely unless we, for some reason, caught it super early. Most of the time for an early stage NEC, we would offer curative chemoradiation, and hopefully a subset of a patient would have long-term disease-free survival. Majority of patients, however, would still relapse, and that's the aggressive nature of this cancer. For metastatic disease, where the cancer is already present with aggressive pattern of spread and multiple organ involvement, there is usually no role for surgery outside palliation, and we treat them with medical therapy, with either chemotherapy or immunotherapy or a mix of these. So let's talk first about NEC. How do we treat NEC? Again, most significant advancement has been made in the last 30 years in about how we go about treating NECs. The treatment options for NECs usually follow small cell lung cancer paradigms because that's the most common type of high-grade neuroendocrine carcinoma. However, there are some nuances, as I mentioned before, especially in large cell neuroendocrine cancer, because we are understanding a majority of large cell neuroendocrine cancers don't really look like small cell when we look in the tumor biology. Platinum-based chemotherapy is still the preferred frontline treatment and has been that way for past 30 years. There, however, has been some inroads made by immunotherapy, and we'll talk a little bit about it. But really, what we should encourage is clinical trial participation, because that is the only way to find new promising treatment for this very aggressive disease. And lastly, we do like to do next generation sequencing or genomic testing of tumor tissue to screen for targetable mutations. NEC tends to harbor a little bit higher incidence of targetable mutation as compared to NET group. The first line chemo for metastatic NEC, which is platinum doublet, cisplatin etoposide or carboplatin etoposide, has been standard of care for past 40 years, since 1980s. Prior to that, we used to use a regimen called CAV, which was equally effective but much more toxic. So when these studies looked into the safety data and efficacy data, they found that platinum doublet was much better tolerated and had equal results. And since 1980s, platinum doublet has been the way to go. Between the platinum doublet, the patients might have heard about cisplatin versus carboplatin. For metastatic disease, I often prefer carboplatin. It is a little bit better tolerated as compared to cisplatin. Cisplatin is very nephrotoxic, can have side effects on kidneys, neuropathies, very tough on patients. However, having said that, carboplatin has its own unique side effects. It is a little bit more myelotoxic than cisplatin. So that means your blood count can go a little bit lower with carboplatin. So you can tailor these between the two platinum agents based on the individual risk factors. However, in general, carboplatin is somewhat better tolerated than cisplatin in most patients, especially in metastatic setting. So after platinum doublet, what are some of the options for high-grade NEC patients? Platinum doublet works quite well in NEC for frontline agent, especially for small cell subgroup. However, the effectiveness of platinum doublet is rather short-lived. Many patients would relapse between 2 to 6 months after the platinum doublet. Then the question arises, how do we treat the patients who've been through platinum doublet? Well, a lot depends on how long did we go after the initial exposure to platinum doublet. If the patient had at least 6 months or longer disease or stability of disease after initial platinum doublet, it is reasonable to assume that the tumor at relapse are still platinum sensitive, and many a times we will re-challenge the patient with platinum doublet. However, majority of patients will relapse within 3 months or between 3 to 6 months, and these patients might need other treatment options besides platinum doublet re-challenge. Some of the agents which can be considered in this setting are topotecan, which is FDA approved for small cell lung cancer, lurbinectedin, another neurocytotoxic, which is recently FDA approved for, again, small cell lung cancer after platinum doublet, irinotecan, docetaxel, CAV. But really, I encourage patients to participate in relevant clinical trials and also get their tumor tissue checked for targetable mutations for the clinical trials, precision medicine clinical trials. That's really the way forward to look for better treatment options. A lot also depends on the site of origin of NECs. So these treatment options are very similar to how we treat small cell lung cancer. However, if we have an NEC patient of GI tract or pancreas, many a time we would incorporate FOLFIRI, CAPTEM, and these agents as a second, third line for management of progressive disease. A small word about immunotherapy, especially immune checkpoint inhibitors. These are the agents which really leverage our immune system, the host immune system, to fight against cancer cells. And there has been some development in this area. Two agents, one's called durvalumab and another is called atezolizumab, are now FDA approved in addition to platinum doublet for extensive stage small cell lung cancer. Now, this data has been extrapolated to treat extrathoracic high-grade neuroendocrine cancer. However, we don't have prospective data yet. There is a clinical trial in that setting that will evaluate whether atezo or durva or similar immunotherapy agent, when added to frontline platinum, can also have benefit, but is yet to be proven for extrathoracic high-grade neuroendocrine cancer. However, there is some data to suggest that immune doublet with ipi-nivo, ipilimumab and nivolumab can show some benefit. And this is based on a small but multi-center study called SWOG-DART 1609, where about 18 or 19 patients with high-grade neuroendocrine cancer were treated with ipilimumab and nivolumab. And the study group found about 44% of these patients had a favorable response to the treatment, what we call as objective responses, the tumor shrunk, which was very, very promising. Having said that, the other studies using immunotherapy in neuroendocrine cancer, both low-grade and high-grade, has not been as optimistic as DART, and this is so far the only study showing these promising results. So, to reiterate, the second-line options include clinical trials, which I highly encourage, getting the tumor tested for next-gen sequencing to look for targetable mutations and relevant clinical trials, topotecan, irinotecan. I often prefer irinotecan over topotecan, much better tolerated, better infusion schedule. Lurbinectedin for small cell lung cancer. Immunotherapy definitely have a role, is FDA approved in small cell lung cancer. Ipi-nivo is another agent for extrathoracic high-grade neuroendocrine cancer for second, third, fourth line based on patient need. And some other chemotherapies, including CAV and docetaxel, can be considered in certain patients. Last slide. So the management we talked so far was regarding NEC. How do we go about treatment of grade 3 NET? Friends, I would be honest, this is a relatively new disease. WHO included grade 3 well-defined NET in the classification in 2017. We are in 2022. So we have very limited time to learn about this such a new disease. So there is no way we have prospective clinical trials and FDA-approved therapies for this specific subgroup. And this is also a very rare subset of high-grade NEC, neuroendocrine cancer. So knowing that, we have some challenges in how to treat this disease. I highly encourage patients to seek a second opinion. Patients should see NET experts, because this could be a very challenging disease to treat, and it's a very heterogeneous disease. That means that each patient can be very different from the other patients. Some behave more like NEC, the other behave more like low-grade NET, because there's a big spectrum for well-defined NET. Anybody who has high Ki-67 more than 20% is grade 3 NET, but you can imagine a Ki-67 well-defined NET of 22% would behave very differently than a Ki-67 or 75%. So the treatment really has to be tailored and individualized. And what are some of the factors that we use in determining how we would treat a well-defined NET? Ki-67 clearly. So if the Ki-67 is in a lower end of spectrum, that's a good sign. And we might be able to use treatments which are akin to well-differentiated grade 1, grade 2 NETs. The other factor that I personally look for is somatostatin receptor expression. So if there is a very high somatostatin receptor expression, we can consider PRRT. In fact, there are 2 prospective clinical trials looking for PRRT in grade 3 well-differentiated ET. I also like to get Ftg Pet because if there are low SSTR expression or high SSTR expression, but at the same time, there are some clones of cells, tumor cells, which are hypermetabolic that can change the way I treat the particular patient. So having an extra layer of information with FTG Pet tells me how hypermetabolic the disease is and gives me some level of confidence. What should my treatment target first, towards the high grade component of disease or towards the low grade component of the disease? So I encourage getting both somatostatin receptor PET and FTG PET and take both these set of informations in account before we come up with a treatment plan. We also look at tumor burden. The tumor growth is very critical. If there is a patient who is presenting with a lot of weight loss, a rapidly growing tumor, regardless of what the pathology is saying, we know this is an aggressive disease, tumor is growing very fast, and we're going to institute cytotoxic chemotherapy, be it with platinum-based chemotherapy or CAPE-TEM, based on the tumor patient needs. However, if we are treating a grade 3 well-differentiated ET, Ki-67 25%, but very slow-growing asymptomatic patient, we might have some time to get these additional testing, the SSTR imaging, the NGS testing. And if the patient is behaving more like grade 1, grade 2 NET, we might be able to use the NET treatment strategies as compared to going straight to the chemotherapy. And lastly, I do advocate for checking NGS in tumor tissue to screen for actionable mutations. Again, the goal is not to start the treatment. The goal is also to come up with plan B, plan C, plan D right up front. Because regardless of what treatment we start, sooner or later, these tumors start developing resistance to the treatments and would start progressing. So we need to work ahead to have a long-term strategy for the patients. With that, I would wrap up my talk. Thank you so much for having me here, LACNETS, and I'll be happy to take any questions now.
Great. Thank you so much, Dr. Chauhan, for a really excellent presentation. It was very informative, and we're really thrilled to have you for a Q&A.
Thank you, Lisa. Thanks. I'm honored to be here. And hello, everybody. I hear there are viewers from all over the place, all over the globe, actually. So greetings from Kentucky.
Well, it's great that in this virtual world, we can join each other from across the country and even across the world. So with that, let's get started on some of these questions. There's some really excellent questions that have come in. And the first one, you talked a little bit in the beginning about grading. What's known about the features of NETs that may result in tumor grade changes, such as a grade 1 or grade 2 NET changing to grade 3? And a follow-up question is, can the Ki-67 index decrease so that a grade 3 turns to a grade 2?
That's an excellent question. And we are still in a very early phase of understanding the switching of grades. Because to do these studies, we have to have multiple biopsies from primary tumor to metastatic sites, and also evolution of progressive disease. So serial biopsies at baseline and at progression, and then sequencing all these tissues and collecting all these data. So as you can see, the challenges behind learning that pattern or evolution of the biology. However, there have been few studies which kind of throw some light on this concept. So there's a very interesting paper from University of Iowa which studied primary tumor and the metastatic lesions and did the genomic sequencing. And what they found, up to 1/3 of patients actually have discordant grades. So there is difference between the primary tumor and the metastatic lesion, right? Up front itself at the time of diagnosis. So there are these changes. Most of the time, actually 24% of the time, this is usually the metastatic lesions are usually higher grade. So for example, if the primary tumor is grade 1, the metastatic might be grade 2. So that's a more common phenomena between when we see these changes. However, a small minority subset in their group, about 10% patients, did tend to have a lower grade in metastatic disease as compared to primary. And again, these were majority of these patients were between grade 1, grade 2. Now, when we talk about switching between grade 2 to grade 3, the data is even limited there because grade 3 well-differentiated NET is a very new disease, as I described in the presentation. We recently incorporated this entity of well-differentiated grade 3 NET in 2017 WHO classification. So once the pathologists knew about it, and now they started coding or signing out well-differentiated grade 3 NET, and we start recognizing this entity in the clinic, uh, the research on this particular entity is very limited. So we'll have to see. However, I can foresee, just like grade 1 can upgrade to grade 2 in some patients, similarly, a grade 2 patient can also become more aggressive at time of progression and flip to grade 3. This is not a common phenomena. Again, the switching of grades noticed only 1/3 of the patients, and this upgrading is about 1/4, so about 24% of the patients. This is again can happen. We have to always, be open to the idea that the cancer can become more aggressive, and if we, especially when a tumor becomes from a slow growing tumor to a very fast growing tumor, I always encourage a repeat biopsy so that we can understand, is there a change in grade, or are we treating the right biology? And scans like somatostatin receptor imaging and PET scan does help us to non-invasively understand the biology of the disease. Is it too hypermetabolic, and etc. So certainly we are learning about these. Hopefully we can throw more light on these nuances of grade changes over the period of time in the near future.
Thank you for that. And in that answer, you also read this person's mind who asked, is it typical that liver metastases have a higher Ki-67 index? Was there anything else you wanted to add to that?
Correct. So about 1/3 of the patient can have a different Ki-67 between primary versus metastatic based on this single center data, and usually the metastatic site has a little bit higher grade as compared to primary site. That's a more common phenomenon than other way around. But again, 2/3 of the patient would still have same Ki-67 between primary and metastatic lesion. So it's only 1/3 that they can show a discordance between primary and the second metastatic site.
Okay, that's helpful to know. And as you said, there's a lot we have yet to learn. But just curious, are there certain NET primary lesions that have a higher incidence rates of changes in tumor grade?
Another great question. So most of our understanding of these evolution of grading or changes of grades between primary and metastatic sites and with the progression comes from GI neuroendocrine neoplasms, so LACNETS and other GI origin neuroendocrine cancers. Primarily, I think because it's easy to biopsy liver mets and GI origin tumors. We still don't have a whole lot of data when it comes to lung neuroendocrine neoplasms and how they evolve with time, especially the, the atypical carcinoid and poorly differentiated neuroendocrine carcinomas of lung origin. The tissue is limited, and often that is the reason cited for lack of our advances in understanding the molecular biology of these diseases, because it's not easy and it's a very, very challenging organ to get large core biopsies because of the risk of lung collapse and other issues. So it's not easy to repeat biopsy lung cancer patients at progression and let's suppose a large cell neuroendocrine cancer of lung, etc. However, there are some newer studies trying to study these challenging patient populations. So I can't really say how which net primary have a higher incidence of tumor change, because we haven't studied all primary sites to kind of give you a very accurate answer. But among the GI ones, it seems like the pancreatic neuroendocrine tumor tends to be a little bit more on a higher grade, um, based on my experience and based on what I read.
Thank you for that. And again, you already touched on when you might repeat a biopsy. I just want to see if you had anything else to add to when you would.
Great. So it's a very, very good question. And previously, we would only need biopsy once at time of diagnosis to confirm the diagnosis, and biopsy is the gold standard way to have a diagnosis, and that's the only way to know which grade of tumor, etc. But as we are developing more tools like next generation sequencing and more targeted therapies, we are seeing there could be a role of serial biopsies, because we know, and this is data from Dr. Nitya and Dr. Reedy in Memorial, that the neuroendocrine tumor patients do acquire new mutations as they evolve and become metastatic or progress at time of progression. So there is a possibility that the tumor behavior changes, their genomic, fingerprinting changes. We might have more actionable mutations. Again, it's still not standard of care, but I highly encourage, especially we live in an era where we have a lot of clinical trials and precision medicine based clinical trials to offer, and a newer biopsy would always give us a fresher perspective on what's really happening in the tumor as compared to a biopsy done a year and a half or 2 years back. And since then, patients been through multiple rounds of treatment. Now, where biopsy is really important, or repeat biopsy at time of future progression, if we see a clear change in pattern of the disease or the natural history of disease. So, for example, if patient has a very slow growing cancer for a while and did well on certain treatments, but all of a sudden the tumor growth rate has now significantly increased. That raises my suspicion of cancer changing its grade or morphology altogether and becoming a more dedifferentiated, more aggressive cancer. So I definitely like to get repeat biopsy in those situations. The other place where I would consider repeat biopsy is if there is a lot of heterogeneous disease. For example, grade 3 well differentiated NET, and patient during diagnostic workup got EGD, EUS, and got a pancreatic biopsy, and we found the tumor, and it was graded a particular way, and which led to further diagnostic workup, including further scans. But on scanning, the tumors in liver are looking more higher grade, either on the PET scan or a lot of tumor necrosis on CT scan that kind of questions the original diagnosis. So I might repeat a biopsy in a heterogeneous disease at a different site to really get a better idea of what is the true nature of the disease. So there are a lot of reasons why we repeat biopsies at the baseline, at the follow-up. It shouldn't be done routinely because, again, at the end of the day, these procedures are not completely benign. I myself don't like to get stuck, so I can't advise all the patients should go for biopsies, but there's certainly a role, and these nuances should be discussed individually based on the individual situation with your provider. I do see a role for biopsies, though.
Great, thank you. And someone asked this follow-up question. This is an excellent question. If a primary site was found later after the metastasis biopsy, is it needed to make, do you need to do a biopsy of the primary site?
Excellent question. Usually not. If we have a biopsy proven cancer in metastatic lesion, and based on the scan we know the primary site of the origin, we don't have to necessarily prove that the primary is consistent with the metastatic disease. Okay. Now, when would we do these both the biopsies is on those very unique situations where the tumors are not behaving in a very consistent way. Certain tumors in the body, certain clones are more aggressive than others. Fortunately, that discordant or heterogeneous biology is very rare. It's seen in grade 3 well-defined NETs to have that heterogeneity, but most of our grade 1, grade 2 NETs, most of the disease behave very similar. So if a grade 2 NET patient, most of the disease would have a very homogeneous disease on their net spots and on the so there is really no need to rebiopsy the primary site, especially when we have a metastatic site biopsy. Again, so in general rule would be that metastatic biopsy is good enough and we don't have to go for another biopsy. But for those very unique scenarios that I mentioned before, that you can consider repeat biopsies if the doctor has a suspicion that these tumors are not behaving the same way, and there is suspicion that there is a completely different etiology going on. Could there be two separate cancers or different grades of the same cancers?
Great. That's really helpful. And another follow-up question, would you biopsy a tumor at new sites of metastasis, such as if it spreads to the bones?
So I would, but again, I have to be judicious with these things. So I do not biopsy everybody at every progression. So whenever I see that there is a significant change in the pattern of the disease spread or the tumor growth rate, that's one of the times that we should consider. If there are promising clinical trials these days, a lot of our clinical trials are targeted therapies that we like to screen the tumor tissue for particular antigen on the cancer or target on the cancer, and there's not enough tissue, so we need to do repeat biopsy to screen if the patient would like to consider that clinical trial. So so those would be situations where I would consider repeat biopsying. It shouldn't be automatically done at every single progression, because again, these procedures are not completely benign, have risk, pain, bleeding, and financial toxicity. So we should know what we're going to do with that information. Many a times when we repeat the biopsies, often for a clinical trial or as part of a screening for clinical trial, that we need a tissue to screen patients for certain specific studies. But outside the clinical trial, it is often done if we suspect that there is a significant change in the way the tumors are behaving. But I would not routinely do it at every progression.
Okay, that's helpful. Really good answers here. So let's move on to some questions about treatments. There's a lot that have come in this realm. Why are G3s generally described as inoperable?
Another great question. So like we discussed in our lecture, G3 can be either G3 NET, well-differentiated neuroendocrine tumor, or G3 NEC, poorly differentiated neuroendocrine carcinoma. Now, in my experience, G3 NECs are often diagnosed when it's already spread. It is a very fast-growing cancer. By the time patient present to the doctor, there is often regional or distant metastatic disease. The patient presents with inoperable disease, and the cancer is already outside. The cancer cells has migrated out from the primary tumor. And many of the NEC patients, if I do a blood test, I can actually find circulating tumor DNA. So a metastatic disease is a systemic disease. It's like high blood pressure or diabetes. You can't fix it by taking one particular organ out. So it is a systemic disease. It's the tumor DNA circulating all over the place. We might be able to see it just in places where the CT scan is showing us, but there is microscopic disease much beyond what we can see. That's why a metastatic disease is inoperable, and most G3 patients often present with metastatic disease. Having said that, it's a small minority of G3 cancers do present early. And if they do present early, there could be a role for surgery. So it depends. This often happens in lung. because there is a lung cancer screening program, especially in smoker patient population. They get low dose CT to preempt and to look for these early cancers in lung, and a lung nodule might prompt surgical resection, and that's when we find a lot of large cell neuroendocrine cancer of lung in surgical specimens, and it's caught early, so it's operated. But the high grade neuroendocrine cancer of GI origin, by the time we detect, it's often metastatic, unless we find it very early during a colonoscopy, and then yes, surgery could be a possibility. So it is inoperable because most of the time we find it in metastatic setting where the cancer is already spread and there is a lot of microscopic disease floating around, and visible disease in different organs, so we cannot operate everything. Take these clones of cells, a clone of cancer cells out with just surgery alone, and systemic therapy is the best way to treat it in that case.
Thank you for that. So there's more work to be done for earlier detection and treatment, it sounds like. Okay. Here's another question about treating high grade. How do you treat skin mets of small cell high grade neck? And if they are large and growing outward, is it safe to remove them surgically?
Interesting question. And I have actually seen quite a few cutaneous high grade neuroendocrine cancers. So it depends. So for small cell, usually, at least in my practice, whenever I've seen small cell cancer patients with lesion in the skin and we biopsied them, it turned out to be metastatic sites of small cell. It's often a metastatic disease, and I would not recommend surgical removal because the primary site is somewhere else and there's a lot of other metastatic disease, and just by taking that cutaneous lesion out is not going to help the overall picture. However, if there is a particular cutaneous lesion very painful and is infected, or there's some reason that it needs to be resected for symptom control, we call it palliation, then it can be considered for that particular patient. But in general, when the tumors are infiltrating the skin, especially for small cell, it's usually a metastatic disease. And in metastatic setting, again, surgery is not recommended because it is a systemic disease. Just by cherry picking a one particular skin lesion is not going to fix rest of the disease. So why to subject a patient to an unnecessary procedure? Having said that, if for some reason that primary lesion is it is a primary small cell of skin, it's extremely rare, but small cell carcinoma can happen anywhere in the body, from cervix to pancreas to ovaries to bile duct to lungs, right? These outside the lung, all small cell constitute just 5%, so very rare. And a small cell of skin would be extremely rare. So for some reason, if the patient was detected with primary small cell carcinoma of skin and it was still local disease, yes, surgery can be considered, and then post-surgery you'll do some radiation and adjuvant therapy based on individual patient staging. The other high-grade neuroendocrine cancer, like small cell, is just one type of high-grade neuroendocrine cancer. There is a cutaneous cancer called Merkel cell carcinoma, which is a very sister cancer of neuroendocrine cancer, and it is a high-grade type of neuroendocrine cancer. There, and it is often it's a type of skin cancer. So when it is caught early, yes, the treatment of choice is surgery, and after the surgery, based on the depth of invasion, etc., patient would get local therapy with some radiation, or if there is some risk of metastasis or local lymph node involvement in chemotherapy. So it depends on what type of high-grade neuroendocrine cancer we are dealing with, but there are some high-grade neuroendocrine cancers like Merkel cell where there could be a role of surgery if it caught early in stage. But if the small cell is a metastatic is a part of metastatic disease in skin, I would not recommend operating on metastatic disease.
Thank you for that and for covering the range of other types of skin high grade that there are out there. So this is an excellent question. Can G3 be treated with somatostatin injections if they have good receptor population on all cells?
Great question, and something that we have to study in more detail. Fortunately, our friends from Mayo Clinic shared their experience with use of somatostatin analogs in G3 neuroendocrine cancers. It was a very small patient population, so it's a retrospective review. That means they looked back into their database and saw how many patients with G3 neuroendocrine cancer got treated with somatostatin analogs and how they did. So there is some benefit. The median PFS reported in this small series were about 4 months. So you can see the benefit is very modest. So metastatin analogs, the median PFS in grade 1 and grade 2 are in several months to several years. But for high grade was just 4 months in their retrospective review. Having said that, G3 is a disease type where we don't have many options. So if there is a subset of G3, especially G3 well-differentiated NET with high somatostatin receptor, and we are running out of treatment options, for example, PRT has been done, CAPTEM has been tried, and now patient has progressive disease. If there is absolute lack of disease and patient would like to try, somatostatin analogs can be tried in this kind of setting. Although I am not very optimistic that for an aggressive biology like G3, the somatostatin receptor would control the disease for long, and that's what we saw in the Mayo Clinic paper. Now, having said that, there are some clinical trials looking at G3 well-differentiated NET patient population. These are the ones with high somatostatin receptors, and they are G3. One of the studies, NETTER-2 study. So the treatment arm is PRRT, and the control arm is high-dose somatostatin analog. So clearly, when the people and investigators designing the study, they did consider that somatostatin analog is a reasonable choice to treat in control group. There is a rationale to use somatostatin analog in well-differentiated NET with somatostatin receptor presence. We will see how the NETTER-2 data comes out to know what was the true activity of using somatostatin analog in G3 patients. I'm a little reserved in my expectations, but certainly don't want to throw this option out of the window, especially when the options are so limited in receptor positive G3 well-differentiated NETs.
That's exciting. And when can the audience expect NETTER-2 data to come out?
So this is hopefully, again, I don't know how much, we are one of the participating sites, and this is sort of confidential. I'll leave it up to the sponsors of the study. There is also another study similar to NETTER-2 called COMPOSE study, again, looking at the high-grade neuroendocrine cancer population, PRRT versus standard of care. And there, I think you have a couple of different standard of care, or it's a dealer's choice, a doctor's and patient's choice of control arm. However, I'm hoping that in next several months to several years, we'll have these data ready.
Great. Great. We look forward to learning more and hearing more. And so, you're talking about somatostatin receptors. A couple people asked the similar question. When you treat grade 3 NET with PRT, how would you tailor the treatment compared to grade 1 to 2? Basically, is there any difference?
In terms of how I would prescribe PRRT, I would follow the same prescription as done in grade 1 and grade 2 NET. Because the regimen, the PRT regimen, the dosage and the frequency, like 200 millicurie every 8 weeks times 4, has been now studied in a very well-run NETTER-1 study, and we have long-term safety data. And that's the prescription which FDA has now approved in grade 1, grade 2, well-differentiated GEP-NETs. So because there is considerable safety data, and we know we have the comfort level how to do that, that's what we usually replicate in the grade 3 well-differentiated with somatostatin receptor positive disease. I would hate to alter the well-studied regimen. Now, many times in real world, what happens is patients after one dose or two dose, based on the individual patient scenario, they can have certain issues. For example, grade 3 NET patients might have had multiple rounds of chemotherapy prior to PRRT. So their bone marrows have already taken a beating. So they develop thrombocytopenia, neutropenia, lymphocytopenia, or higher risk of cytopenias with PRRT. So we might have to lower the dose or increase the duration between the treatment doses so that we can give some time for their bone marrows to recover. So those would be the changes I would consider on an individual basis based on how well they are tolerating the PRRT. But right off the bat, to begin with, I would do the PRRT the same way that has been FDA approved for GEP-NETs, if that's what we are extrapolating to grade 3 well-defined NET.
Thank you. We know you have a lot of experience in this PRT area. So here's another question that came up about treatments. A CAR T cell therapy study for NET is starting this year in the USA. Preclinical studies are very promising. Could this be a possibility for the future and timeline?
I hope so. I am very optimistic about immunotherapies in general. And immunotherapies are a type of treatments, anti-cancer treatments, that uses or leverages our own immune system to fight against the cancer. So very different as compared to chemotherapy or radiation-based treatment, where the chemotherapeutic agent or radiation is causing either DNA damage of the cancer cells or not. Here in immunotherapy, we are using our own host immune system to fight against the cancer. And the big immunotherapy that is very popular in oncology world these days are immune checkpoint inhibitors, nivolumab, pembrolizumab. So you've probably heard about these names of Devo and Keytruda, etc. And there are so many more. Similarly, there are other types of immunotherapies under investigations, and some are oncolytic viruses. These are viruses we have engineered and to kill cancer cells specifically and leave the normal cells intact. And we inject these viruses into the tumor where they grow and destroy the tumor and release the antigens, and that sensitizes the immune system to also go ahead and kill the non-injected lesions. And we have a very similar trial recently opened for accrual at Markey Cancer Center. Similarly, there are cancer vaccines where vaccines developed which against a particular antigen seen in a tumor, could be neuroendocrine tumor, and then you try to raise autoimmune response towards that cancer. And similarly, the other leg of immunotherapy is cellular therapies, and CAR T falls under that cellular immunotherapies, where we take the immune cells from the actual patient and we bioengineer that to fight against the tumor cell and inject that back to the patient. So it is a little bit elaborate process. Each patient gets a very individualized therapy, tailored towards their particular cancer. And there are certain risks and challenges associated, like cytokine release syndromes, etc. But these therapies have really revolutionized certain areas of oncology, especially blood cancers. Leukemias, lymphomas is where we have seen the most utility. And now we are increasingly studying CAR T therapies in other solid cancers, including neuroendocrine cancers. However, what's the timeline futures look like? This is very early. And solid tumors, in our experience, are very different than treating lymphomas and blood cancer. So I like to be eternally optimistic. Good luck to the team of CAR T therapy. I hope this is the breakthrough we are looking for. But I think it's going to be all these areas of therapeutics, be it radioligand therapies, radiopharmaceuticals, be it different type of immunotherapies, oncolytic virus, immune checkpoint inhibitors, immunomodulators, immune vaccines, and CAR T therapies, that together we have to try different things, and hopefully some of those things turn out to be the breakthrough we are looking for.
Yeah. Well, we appreciate that optimism. And it's clear when you start talking about the clinical trials that are out there and work being done, you get excited. So this is a good time for this question. How do we find out what clinical trials are available for high-grade NET or NEC?
Great. So the best resource in my experience is clinicaltrials.gov. Now, it's not ideal, but that's the best we have so far, where you can find the most number of trials listed in the world. And it's a government maintained website, and it has a lot of filters that I encourage you to use. So when you type in buzzwords like neuroendocrine tumor, neuroendocrine cancer, high grade neuroendocrine cancer, so you'll have to use your imagination based on your diagnosis and punch that word kind of like Google, and then often use the search criteria where you can screen off all the completed trials or the trials which are closed, and there'll be multiple options. So only look for active trials or open for enrollment, etc. And then you can filter the list. The good thing about this website is open for all. You don't have to register, you don't have to pay for this information, nothing, it's free. And then when you click on this information, there would be a contact person uh, listed. So you usually get a number there, and you can call that number. That could be the investigator's office or research nurse or somebody associated with that clinical trial, and really query them. Hey, this is my situation, would I qualify for your study? And then they can at least tell you the next step. The clinicaltrial.gov would also give you some inclusion exclusion criteria, so where you can self screen if the trial is only looking for small cell lung cancer. So if you have small cell cancer or pancreas, maybe you're not the candidate for it. But again, call that number and you can confirm if that's the case or you're interpreting it right. So clinicaltrials.gov is a highly useful website. You have to spend some time because there are different trials and they're coded in different ways, especially when we are talking about a rare cancer like NET. If you're specifically looking for grade 3 NET, you might have to use a couple of different search words, but you might be able to find some useful information. And lastly, the clinicaltrials.gov also tells you where all this particular trials open. So many trials are multi-center. You can easily look into the list, and maybe the one of the sites is available, is very close to you. So that's really a good thing. Another good thing about checking trials to clinicaltrials.gov. And this is the last thing to add here would be many times when you seek second opinion with an expert in this particular area, since these experts are only dealing with this particular disease, oftentimes they are more up to date with what clinical trials are happening, at least in their vicinity. So that could be another resource. So do ask them, hey doc, are you aware of any good clinical trials? For example, I only deal with neuroendocrine cancers, both high grade and low grade. So I may be aware of some clinical trials. I won't say all clinical trials, but I don't know much about what's happening in the breast cancer clinical trial world. So that could be one of the reasons you seek a second opinion to screen for some clinical trials.
That's a good point. Really helpful. Thank you for that. So this is a good question that came up. You talked about platinum-based therapy. Dr. Chauhan, how many platinum-based cycles are needed? Is there a minimum or maximum?
Great question. So usually we give between 4 to 6 rounds of platinum-based chemotherapy, cisplatin etoposide or carboplatin etoposide. We often don't see a lot of benefit extending after 6 rounds, and we see considerable amount of side effects with every single cycle stacked on after 6. Many a times I often stop off after 4 rounds. But if I have a very fit patient who has had absolutely no side effects and doing very well and had a significant response, I might extend it and give up to 6 rounds. So between 4 to 6 are considered normal and reasonable without affecting the quality of life. If and we are, especially we are talking about extensive stage or metastatic disease, one of the key goal for us, because this is a non-curative disease in metastatic stages, is to preserve quality of life. So even if the treatment's working, if we are going to give terrible side effects or put patient at risk of considerable thrombocytopenia or neutropenia and risk of infection, then that doesn't justify what we are doing. So 4 to 6 cycles is a happy medium, and then we give some break from the chemo, and then some patients would have a prolonged um, disease-free survival. So the tumor might not relapse for 6 7 months, and if it can cross that threshold of 6 months of stable disease after platinum, then we can re-challenge again 4 to 6 rounds based on how well the patient is and the organ functions of the patient and the blood counts of the patient. So we can redo it at the time of progression. But if this relapse happened within few months of stopping platinum, there's a big likelihood that the tumors are platinum resistant. So I often do not re-challenge them with the platinum.
Right. Thank you. And similarly, this question comes up. My husband's having platinum-based therapy, 4 cycles, and the somatostatin analog at the same time. Is it correct to have both? So basically, can you have somatostatin analogs at the same time as platinum-based therapy?
I can't comment too much specifics about this individual case because these are two very different types of therapies. We often don't mix because platinum-based treatment is often targeted towards poorly differentiated neuroendocrine carcinoma, the NEC that we talked about, and the somatostatin analogs often are well differentiated NET grade 1, grade 2. So somebody to have been on both these agents, I presume the diagnosis might involve a grade 3 well-differentiated NET with high somatostatin receptor, where the physician thinks that somatostatin analog might have a role, but since it is a grade 3 MR high aggressive cancer, then they felt a need for platinum-based chemo. Again, so I don't have all those fine details about the case, so it's very difficult. But let's suppose for whatever reason the patient is on both, from safety wise, I don't think there are any concerns. Somatostatin analog is a very benign drug as compared to chemotherapies and other targeted therapies. Many times we do not combine chemotherapy agents because of safety concerns, unless there is a phase 1 data which has proven that two drugs or two different agents can be safely combined. So we will not combine platinum with Captem or platinum with Afinitor. But somatostatin analog is a unique exception to that rule because somatostatin analogs is a relatively much benign drug. It does have side effects. It can cause some high sugars and some cholesterol issues, but comparatively doesn't affect your blood counts to an extent where this is a safety concern. And in fact, Lisa, you probably are aware that in our low-grade, well-differentiated NET patients, many times we continue somatostatin analog for functional hormonal syndrome control, regardless of whether they are on Captem or Afinitor or PRRT. So somatostatin analogs has a good track record of combining with other anti-cancer agents safely. So just from safety perspective, yes, it can be done. Why is it being done in this patient? What's the rationale? That I cannot comment because of I don't know the case specific details.
Of course. And thank you for just offering that comment. So we're about closing, but just want to get a couple more questions. Can a person have grade 2 and grade 3 at the same time?
Yes, I think patient can have grade 2 and grade 3 at the same time. Um, and I have seen discordant disease with heterogeneous disease where low grade tumor exists with the high grade tumor. I've also seen grade 3 NET with poorly differentiated NEC. I've also seen low grade 1, grade 2 NET with poorly differentiated NEC. So I have seen all sort of permutation and combinations. So yes, it can happen. It does happen. Fortunately, it's not common, but it can happen. Sometimes it happens because one of the tumor tissues might be inadequate for complete assessment of grading. So that one of the grade could be inaccurate, and the other tissue, other site had a better core sample, and the pathologist had better information to interpret. So it could be for that reason as well. But it's also completely possible the patient had different grades of disease at the same time. Just like how we can have different tumors at the same time, These are called mixed neuroendocrine, non-neuroendocrine cancers. So I have seen patients with mixed component of adenocarcinoma with neuroendocrine tumor, squamous cell carcinoma and neuroendocrine tumor. So all sort of permutation combination can happen, and that keeps us on our toes and keeps us looking for more reading and more research and learn more about these different variants.
Yeah. Not just a zebra, it's more like a unicorn, isn't it?
Yes.
And let me just also take this question because this comes up in our support groups too. Basically, can you repeat CAPTEM? So can you use CAPTEM again after 40 cycles and a chemo break, say of 3 years with new progression of disease?
Yes. So again, we are in a sort of uncharted territory. CAPTEM, especially the TEMODAR, the TEM part of the CAPTEM, is what we call an alkylator-based chemotherapy and has a known side effect of causing secondary cancer, especially leukemias and myelodysplastic syndrome, a type of bone marrow disorder or cancer. That is the reason why we usually shy away from continuing too much of CAPTEM. Because even if it's working, at some point of time, the risk benefit ratio shifts towards the risk side of the things. And we often give chemo break, even the patient's doing great. Now, after the chemo break, and this looks like a pretty good scenario where patient had good chemo break for 3 years, can we re-challenge with CAPTEM? I think we can. However, the factors that you have to weigh in is, are there other alternative treatments which have less risk of myelotoxic side effects, leukemogenic side effects? And if there are, then maybe consider that, because you've already gotten 40 rounds of chemotherapy in past, so your bone marrow has taken quite a bit of beating. So that would be one factor to consider. What are our alternative options at this point in time? The second thing would be, let's suppose if there are no other alternative options and we have exhausted some of our other options, then it depends on how well is your organ function, especially bone marrow functions. How's your platelet count? How's your blood counts? Are they permissible enough to do retreatment? And if they are, then yes, cautiously you can restart and tailor the dose based on how well you tolerate it. Many a times after so much of CAPTEM, you might have to dose reduce because of thrombocytopenia or low platelet effects. So those would be two factors I would consider, your alternative options versus how well your bone marrow is doing at present, and kidney function, liver functions, but bone marrow function, most importantly, your blood counts, your platelet counts, and white blood counts.
Thank you for that. I think we could keep talking, but we have to end sometime today. So let's end with this question, which is great. What words of hope can you offer to the high-grade neuroendocrine community?
I think this is the best question and the most important question. We really need optimism. We need advocacy. We need everybody to advocate for themselves and for our patients. High-grade neuroendocrine cancer has been long avoided or not focused on. We have made huge strides in cancer world in general when we come to lung cancer, colon cancer, breast cancer. But if you look at high-grade neuroendocrine cancer, we have hardly made any advances in the last 30 to 40 years. But to answer your question regarding hope, I'm very optimistic and hopeful. There is a whole new generation of investigators who are focused on this challenging subgroup of disease where we have very limited options. And I am so thrilled to see that NANETS, organization, patient advocacy groups like LACNETS, NCAN, and so many others, Carcinoma Cancer Foundation, they are really encouraging investigators to focus on this, giving us platform to educate other people about what high-grade neuroendocrine cancer is, so that we can raise awareness about this critical unmet need. This helps us to also raise awareness between the NCI and industry to focus on clinical trials. And if you look into the clinical trial, um, in this particular space, there be now mushrooming of clinical trials, and we really needed that. So we are now looking at various promising novel agents targeting neuroendocrine cancers, both high grades and low grades. Especially for high grades, it's very heartwarming to see that the industry is jumping in, they're focusing on this disease, and neuroendocrine cancers, regardless of GI origin or small cell origin, there's a lot more drug development happening as compared to 10 years back. So that makes me feel optimistic, and clinical trials is the only way out for us to find a breakthrough in this very challenging disease. So keep advocating for yourself, educate everybody around you about this particular zebra among the zebras, and hopefully we together can find a cure in my lifetime, and at least that's one of my goals for my academic career. So I am optimistic, and I think there are better and brighter things in the near future.
Thank you for that optimism. We definitely need that and appreciate that. One of our viewers said, I just want to thank you for your commitment. And I just want to echo that. We are very appreciative for your optimism, your commitment, all the hard work you do, both on the science side with the research and clinical trials, and also your patient care and then advocacy work as well. So thank you so much for joining us for today, for this fantastic Q&A. Yeah. And before we close today's webinar, we're going to hear from someone living with high-grade neuroendocrine. As Dr. Chauhan was saying, all of this we take into consideration, and Dr. Chauhan and others take into consideration quality of life. So we're going to hear from someone living with high-grade neuroendocrine named Cindy, who's learned how to thrive despite the ups and downs of living with the disease. Thank you again, Dr. Chauhan. And now we'll hear from Cindy.
Hi everyone, I am Cindy and I'm coming to you from the plains of Oklahoma. Lisa asked me to talk to you about living the good life while also dealing with high-grade neuroendocrine carcinoma or neuroendocrine tumors. Interestingly enough, if you look at my medical chart, it has both carcinoma and NETs in my chart, but really I'm more in the high-grade NET category. A little background, I was diagnosed day before Thanksgiving 2018 and was told it was in my liver at the time of diagnosis. Didn't have my resection until January of 2019, and immediately set out to get better physically. My Ki-67 number at the time of diagnosis was 27. And now the latest biopsy that I had done, that tumor was a 38%. So I'm middle to high grade. Anyway, I really appreciate a few of the LACNET programs. LACNETS, the first thing I did once I was diagnosed was I found LACNETS. So I contacted Lisa Yin, and she got me into their Net Connect program, which is a buddy program. And I found it invaluable. So when I went to my first luncheon, I sat at the table. I met my Net Connect buddy, Ms. T. She's fabulous. I hope you're feeling well today, Ms. T. And I love you so much and appreciate you tremendously. And I thank Lisa because she has a real knack for putting people together and she's trained to do this, to actually put the people together who conceivably are a good match. So take advantage of that. So when I went to my first luncheon, I sat with my Net Connect buddy, Giovanna, Josh Mailman, a couple of other ladies, I forget their names because I have a bad memory. And I'm sure Lisa was at our table too, if I'm not mistaken. And they made me, I left that day feeling so full of hope, even though we didn't know I was high grade that day, but still I left full of hope for a good life. And I set out to have a good life, purposefully. The other program that I did, and this was a little later on in the process, was the LACNETS Healthy Coaching Program. They have health coaches. This is not someone, this is like a life coach. They help you learn coping skills to deal with having a diagnosis of cancer, but that crosses over to helping you deal with anything in life. And 2021 gave me a lot to deal with in this life, and I'm so glad that I had the healthy coaching program in my back pocket, and I had all those tools to help me cope with a divorce, breast cancer diagnosis and treatment, neuroendocrine mets, new mets to my ovaries and fallopian tubes, and a cross-country move with our whole family, because even though we're divorced, my ex-husband and I remain very close and very committed to being a family unit, and he is my support to this day. So all of that was very stressful, but I had those skills in place that I learned through the LACNETS healthy coaching. Time to go on to the good life. Figure out what's important to you. When I first started my LACNETS journey, there were a lot of bucket list items, and I met a few of them. I did a big long hike in Europe, 100 miles, 35,000 feet elevation gain and loss. And I did it 7 months after my resection, and I was out of shape, bad shape, when I started in that first month. In fact, I didn't actually do a hike until probably 3.5, 4 months after my surgery. But I worked up slowly, and I sought help to help me get back into shape properly and carefully. So yeah, I had a couple of really big ticket bucket items, but you know, as I've gone through this a little more, my good life bucket list is evolving and is changing. I lost one brother to a hang gliding accident, a bucket list item for him. And my other brother, we almost lost this last fall in an airplane accident. So that changed my bucket list tremendously, those two events. And now most of my bucket list, instead of being these big trips and big exciting hikes, I want time with people. And that's the most precious thing for me, to live the good life. It's going to look differently for you, and it may change like mine did throughout this journey. So on my high energy days, yeah, I'm going to be out hiking. But on my low energy days, when I'm on chemotherapy and it's dragging me down fatigue wise, or I'm going to be having PRRT, I'm sure I'll have some fatigue with that as well. So I'm not planning big outdoorsy, heavily physical things during those time frames, because I need to rest and I need to listen to my body and put it first. So living the good life during those times are coming in my backyard and looking at the deer that wander down. It could be going to an airport and watching. I'm a retired air traffic controller, so I love watching small planes or experimental type planes come and go. So if I'm in a low energy day, if I have enough energy to drive somewhere like that and just sit in the car and watch and enjoy, I'll get a great deal of joy out of something like that. You know, whatever works for you, but always have something to look forward to. Always try to seek some joy in the day. Even on my worst days, you know, the days like when you're in the restroom 10, 12, 14 times. I do find joy in those days too. Those are the days when I watch my children play in the backyard. My children, he's 14. He would be really offended if he knew I called him a child. Point is, find the good life, define what it means for you, be flexible enough to have it change with your energy level, and look for the positive. Get out there and have just a joyous, joyous day each and every day. Make it a conscious decision to live a joyous life. I love you all. Take care. Follow me on @ZebraHiking. It's less hiking these days and more, you know, have a good day. But I'd love to see you there. And thank you so much for listening to me. Take care.
A special thank you to Dr. Chauhan and Cindy for joining us today. Be sure you're following LACNETS on social media. We have Facebook, Twitter, and Instagram. Stay up to date on upcoming webinars and net news. And as a reminder, today's webinar is being recorded and can be viewed on our YouTube channel shortly after the live broadcast. You can find our YouTube channel link below. And now I'll pass it off to you, Lisa.
Thank you, Lindsay. We offer many programs and resources, including our weekly Net support group, a dedicated caregiver-only support group, Net Vitals, which is a downloadable patient-physician communication tool to help you prepare for your medical appointments, and health coaching available to Net patients or caregivers. We encourage you to go to our website to find out more information about our programs, view resources, read blogs, take NET quizzes, and much more. LACNETS recently launched a new podcast featuring local NET experts who answer the top 10 questions in their field. We hope you'll take a listen. We recently released the latest episode last week featuring Dr. Dan Lee from City of Hope, and we will be releasing one episode every month, so stay tuned for more. Please join us for our upcoming monthly webinars. Next month, Dr. Eric Mitra from Oregon Health Science University will discuss the future of PRRT. In May, Dr. Mark Lewis will share his unique perspective of becoming a NET patient and a NET oncologist. His presentation is titled, The Fortune and Folly of Self-Diagnosis. And save the date, Saturday, June 18th, for our 2022 virtual LACNETS Annual Patient Education Conference. We're excited to announce that we have confirmed all our speakers. If you registered for today's webinar, you will be receiving an email to fill out a survey. We would really appreciate it if you take the time to fill it out, as the survey results helps us with our fundraising and support and planning for future events. Thanks again to our special guest for today, Dr. Aman Chauhan. We're grateful for all you do for the NET cancer community. Thank you to Rich at TVP Live and for all of you for joining us today. Goodbye and see you next month.